So I'm Kristyn Spangler. I work for IHA. I'm the Behavioral Health Program Manager.
And I am Rachel Glick. I am a psychiatrist in the department at U of M, and I am currently the psychiatric consultant for the Northville and the Canton clinics. The U of M clinics, thank you.
So get ready, get your smartphones out, or if you're using your laptops to get ready for our Poll Everywhere. There are 3 Poll Everywhere opportunities.
Which Kristyn added to the slides. I did not put those there.
So you send a text. So you're going to text the number 22333, and that's where you're sending it, and you're going to put the Kristyn Spang 287. That will join you in. Kristyn, you're right. Oh, which means that I need my phone because I'm going to have to stop and hold. Yeah, the phone number is 22333.
I should do it to test it, but I'm too lazy to go get my phone.
Poll Everywhere. All right, so our first Poll Everywhere. So maybe use it as a question, so it's not really sure a word you associate with risk assessment.
People have gotten this done.
Yeah, have people gotten...
Oh, we haven't started the presentation.
What do you mean we haven't started the presentation?
It says start presentation to see live content.
No, I think you've...
The app's not. Is that it?
The app should work.
All right, well, I'll text it and see if we get one.
It says we've joined your session.
All right, did you answer a word that you associate with risk assessment? We'll see if it pops up, see if it's working.
It may just go to your phone until you transfer it over, but I don't...
What are we supposed to be doing? Donovan says,
Text in a word.
Donovan says, I think you have to have the app installed on the computer.
Son of a gun.
It should be on this computer, though.
That's not at all fun.
You'll have to pull up the Poll Everywhere website on that computer.
Yeah, it says that you haven't opened a poll yet. So try again when you activate the poll.
I don't know how to do that from here.
So anyway, why don't we, while we're doing that...
Why don't we start the presentation?
Yeah.
We'll skip the polls everywhere.
We'll just ask the people in the room to tell. So are there words people associate with risk assessment? Yeah. Suicide. Crisis. Scary. What was that? Scary. I thought you said security, which would also be okay. Security, scary. Liability. That's one that comes to my mind. Any others? Anxiety. Paperwork. Others? Substance abuse?
Who's going to make a word cloud?
Oh, bummer. That would have been so nice, Kristyn.
And I even tested it. Oh, well.
Oh, well.
Not here, I didn't.
Okay, so there are several types of risk that we assess. Suicide risk is a big one. Violence risk. We look at risk of whether a patient can care for themselves or whether they need some assistance. And then there's risk of abuse or neglect for children or elderly or vulnerable populations. Want me to keep doing this part?
Yeah, do you want?
Okay. So, suicide risk assessment.
Oh, I can cover this.
Do you want to cover this? Okay.
Yeah, that's fine.
We're going to go back and forth.
We do. So I know we've all done this to some extent, right, when we're doing the suicide risk assessment. The first things we hear about are ideation, plan, and intent. Those are the big 3 questions. And at the same time, we know that you can still have a high risk even without those things being present. So we want to make sure that it's not like, oh, well, we hit negative there. We want to look at risk factors as well, thinking about the risk factors. And again, not causation, but what we know about people who attempt suicide, there are some common themes that we see. We see this family history and diagnoses, current mental state, so agitation, anxiety are higher risks, feeling hopeless, insomnia, because we don't, any of us think very clearly when we're not getting sleep. Substance use is a factor that really ups our risk, which is one of the things I know when we are talking in the emergency departments is a big argument, because there's this idea that, oh, I said that when I was drunk, but when I'm sober, I'm not at risk. But is this person going to be drunk again and get returned to risk? So thinking about that when you're evaluating the risk for someone. And access to means, guns being the biggest thing we want to be concerned about. And I know we've been talking in our work group about some means restrictions specifically for firearms, for the simple reasons that guns are so fatal. 80 to 90% of suicide attempt with a gun results in death by suicide. And we don't have a chance to intervene with guns like we do with some other methods. There's some time when you can change your mind or you can have an intervention before somebody is dead from a suicide attempt. Let's think about also protective factors when we're doing this risk. What are the reasons that this person is not going to attempt suicide? Their family and friends, being future oriented. They have plans for what they're going to do tomorrow or next week, what they're going to do in 5 years, things like that. If they're going to school and they're talking about, oh, and I've got to take my exams or I've got to get to work. These are some future oriented examples for us. Reasons to live, why do they want to live? What hope do they have? And then making commitments for safety. So I'm going to throw the caveat in there that we don't contract for safety. That's contraindicated. So we don't ask someone to promise not to attempt suicide, but their ability to kind of think through ways to keep themselves safe in situations that are stressful. And that falls right down then into safety planning. So what are their coping skills? Who do they have that are their resources for supports? Who is going to listen to them and talk with them when they're feeling stressed out? And again, removing the means.
I'm going to talk about, so sometimes we're talking about patients who have made threats or we think are at risk of harming others, which I actually think is in some ways harder to deal with than the suicide, probably because the suicide risk assessment sort of becomes our bread and butter. We see so much of it. It's less common for us to see someone who is thinking about harming someone else, or whether it's an identified person or whether it's just that they're making general threats. So again, we think about the ideation, plan, intent, and also look at risk factors and a history of violence, certain diagnoses, such as antisocial personality disorder, or some psychotic illness, male gender, people who are disenfranchised in any way, so people who are unemployed, homeless, feel like they're not a part of our society, and then access to weapons are all risks that we have to think about. Now, a risk, or if someone makes a threat to harm someone else, that may invoke a duty to warn. And the duty to warn laws are actually case-based laws in states. The first case was the Tarasoff case. So you sometimes hear people talk about having to do a Tarasoff duty to warn, or that that it's a Tarasoff situation. And Tarasoff was actually, I think Tarasoff was the woman who was killed, and her family sued. She was a woman who was in treatment at one of the University of California counseling centers, and the therapist there she wasn't in treatment. Her ex-boyfriend was in treatment at the counseling center, and the therapist became concerned that this man was going to harm her, and actually went to his supervisors at the clinic and said, I think we should do something. I'm really concerned that this man is going to do something. And they said, well, we can't because of confidentiality laws, and so nothing was done. The man did kill this woman, and the family turned around and sued the University of California and the counseling center and the people involved there. and were successfully put into law the fact that therapists and psychologists and others have a duty to warn an intended victim if they think that, if they can identify that victim, and if they really do think that there's truly risk. Now, in Michigan, in some states, that duty to warn has actually been extended to all healthcare providers. In Michigan, it's only mental health providers. So it's sort of interesting to think about how BHCC would interact with that. But what happens in practicality, at least at the U of M system and from surrounding clinics, is that if a medical provider is concerned that someone is making a threat that they think is a real threat, they will sometimes refer them to the psych emergency services, because then if we deem that the patient is indeed a threat to that third party, we do have an obligation to do something about it. And that protects that third party. So basically what the obligation is, according to Michigan state law, is that you have to either treat the mental illness if the threat is due to a mental illness. So if someone is psychotic and delusional and for that reason is threatening someone, you can basically meet your duty to warn by hospitalizing that person and making sure that they're not in the community and a threat. And usually that also involves letting the police know at some point if that person is going to be discharged that they've made a threat. If the threat isn't due to mental illness, and a mental illness that we can treat in a hospital, then the way you really discharge your duty is to inform local police as well as the intended victim. So this can be sometimes a little tricky because you can have times where you know that there's an identified victim, but they're not identified by name and address. They're identified by some relationship to the patient, but you don't know exactly who they are. So it can get tricky, and it's one of the things that we deal with in the ER. So from a practical point, if you were seeing someone or hearing about someone in a clinic, probably what you would do is a petition, which we're going to talk about in a second, to get them to an ER where they could be assessed as a threat to others, and we would take it from there. Yeah, sure.
I'm thinking from a practical standpoint in the primary care clinic where our patients for BHCC would come in, if you're sending them to the ER, then you've done your duty to warn, like, do our BHCC social workers have to worry about, oh gosh, this patient was threatening their girlfriend?
Well, that's, you know.
Do I have to call the girlfriend now? Or now they're at the ER, that they've taken care of that, and so we're okay unless the patient comes back to you.
I think in Michigan, it's a little bit hard to know because of that line between a mental health provider and a medical provider. And, you know, if you're working in a medical clinic as staff of the medical clinic, I'm not sure you still have that same duty. I mean, by law, I think we all feel we have some ethical and moral duty to do what we have to do, but that would probably be a case where you would want to have communication with the ER. I mean, I'm thinking about, we saw a case not that long ago of a guy who told a social worker, it wasn't BHCC, but told a social worker in a medical clinic, I don't think it was ours or St. Joe's, I think it was another medical clinic, but told the social worker that he was thinking about killing someone in particular. And that social worker did petition and have him come to the ER. Yeah, Carla, were you going to say something?
Sure. Since we have folks off-site.
Oh, yeah, that's our collaborative care. BHCC is the collaborative care group at the University of Michigan. So if you're working as a behavioral health provider, but you're working in a medical clinic, I'm not sure how the law would see that. And I think that's the issue. I mean, there are two levels. One is the liability of breaking confidentiality with a patient, if you're not a mental health provider and the Michigan law doesn't require you to report. But I think the bigger concern for most of us would be the other side, that if I don't do anything and something bad happens to a third party, I'm going to feel like I was responsible regardless of whether it's you had a legal duty to report or not.
So, and we had a situation like this in one of our offices. Do you feel like you can talk about it a little, Alana, or do you want me to do it?
And if you talk about it, you should come up with it.
Or Kristyn,
got
you
it.
can talk about it.
So I may miss some of the details, and we had a patient who disclosed at a medical appointment that he was thinking about killing somebody who had abused him, and that person was getting out of jail. He knew where to find the person, and had said something like, "I don't think I could stop myself if I saw the person." I had like a picture of the perpetrator on his phone, and we called police. So he left the primary care office, and we certainly didn't go after him, but we just called the police and gave them the information we had, and they did find him and take him to the emergency department. So whether or not it was related to a mental illness, we did not have to decide, because they could decide that where he's evaluated in the emergency department, but we did go ahead and notify law enforcement, and that matched also our organizational policy for when you have somebody who makes a threat that you believe they or harm someone, let law enforcement know. Did I catch enough of the details?
Yeah, Pat?
I have a question about,
I'm going to repeat your question for the offsite people. Go ahead.
is there a tool, there's not a really good one for suicidal ideation, is there some assessing someone's homicidal ideation? Because I get concerned about, oh, I want to kill my grandmother, and then they're like, I don't really want to kill my grandmother.
Yeah, I don't know of a specific tool. There are, if you talk to forensic psychiatrists, they have all sorts of violence prediction tools. I always think of it as kind of a clinical judgment. It's sort of like, and it's one of my pet peeves working in the ER, is that we now have parents bringing kids in who say, Johnny, who's 8 years old, says, I want to kill my 6-year-old sister, and parents bring them to us. I mean, I think you have to use some clinical judgment of, is this a legitimate threat? But in the case that Kristyn was just talking about, that sounds pretty scary. That this guy's really thinking about it. He may have means. He knows where this person is. So I think you do have to use some clinical judgment. My favorite Tarasoff report case was my very, very, very first day as a psychiatrist. I was on call in our psych ER out in Boston, and the first patient who walked in that day actually came in and said, I want to talk to a psychiatrist. So, they call me the PGY2 in psychiatry. And he says, I'm here because I am going to go kill my brother-in-law, and I want it to be documented that I talked to a psychiatrist right before I did it.
Glad you came in.
Glad you came in, yeah. So, I listened to him and talked to him about why he was feeling that way. And then I said, I think you should know that by state law, I am required to warn your brother-in-law, as well as warning the police in the appropriate town. And he just got pissed off and left. So I called I had some trouble tracking down who the brother-in-law was, but I did call the police in the town that he was from, and they said, oh, these guys do this all the time. They both go to doctors or hospitals and report each other and say they're going to kill each other, and so, I mean, I don't know what illness that is, but that was my first experience with the Tarasoff one.
There is some leeway in the law.
Yeah.
Does anybody who says
Right, exactly. I think it's really, it's almost like, I would say it's almost one of those clinical judgment things where you feel like really frightened. Like you think, this is a frightening situation versus someone who's angry and says, oh, I could just kill him. But when you ask him, would you really kill him? It's like, oh no, I just said that. The other thing you have to talk to them about is, if you're making a Tarasoff reporter, you're trying to judge, does this person need hospital or police intervention, is what's their understanding of what would happen if they killed somebody. That's the other thing, is are they impaired in some other way where their cognition is impacted and they don't realize that, no, you can't just kill someone and walk away. So, anyway.
Well, I was going to say, in the St. Joe's Emergency Department, they tend to lean towards hospitalizing anybody with with homicidal ideation, where you have some kind of identified victim, even if it's not from a mental illness. It just seems like they err on that side. And there's always the argument, like, well, you know, that's domestic violence, report that to police. You don't hospitalize someone because they're going to kill their wife. But nobody wants to be left holding that bag either. But you can leave that up to the emergency department.
Yeah.
But that's part of the process.
And it sounds like St. Joe's Emergency Department then transfers that to their psychiatrist on inpatient.
They do. Or we transfer.
We don't do that at BU, but.
We transfer to the psychiatrist at BCA.
Oh, even better. Okay.
And then I was just going to flip back quickly because of Pat's question about a tool for assessing violence towards others. And I know we went really quickly through the suicide risk assessment, because we've had other times where we've talked about that in here. And this wasn't like a time when, like, we're going to teach you how to do suicide risk assessment, but it really ties in to where we're getting for the rest of the presentation. So I didn't want you to feel like it was that simple.
Yeah. No, these are all really difficult decisions to make, and that's part of why we're talking about it. Yeah.
Can I ask one more thing that I think commonly comes up, and if you're going to address it later on? What about you're talking about a person with one identified victim, right? And I think more commonly we see, I'm going to kill everybody.
Yeah.
Like, people talk to me, I just want to shoot them, or, I mean,
Yeah.
so I hear that often. So I'm sure, like, they just feel really irritable. And I feel sometimes I get flippant about that. I'm like, whatever. But
Yeah.
But is there anything?
I think it's the same. I think you have to go through the same process of assessing clinically how frightening that is. You know, and I think that if somebody really is making a threat that you feel is legitimate, then you have to think about, what's my next step? Is this a psychiatric issue and a hospitalization, or is this a police issue?
We saw something similar to that again in St. Joe's, for somebody who was an Eastern Michigan student and said something to someone like, you know, sometimes I just feel like I'm going to shoot everybody. And because of shootings that happen on campuses, like, nobody was fooling around with that. And it was almost like it didn't even matter what he said after, like, that he was going to be hospitalized and the psychiatrist could evaluate it. So again, like, our job is to, like, not have to do that assessment.
Yeah, Wendy?
Was there anything that could be in the note of what had happened? Name was.
We don't.
Can you repeat?
Yeah. So
The question is, oh, sorry. Well, we're going to say this in tandem. No, the question is, are there specific policies or procedures around documentation if you do make a report? And I can say that I don't know of any specific rules at the university hospital. I know we do document who we talked to, what the phone number was, you know, a summary of the conversation. I don't know whether you have anything different.
Yeah, we don't have a policy about how to document it, but I certainly would say you have to document enough so that it's clear what action you took and what the reason was, in case that is called up for any reason, whether an audit or because of the person's in big trouble.
Yeah. You want to take this one, or you want me to?
I'm happy to do this one. So we've talked about kind of, you know, suicide risk of homicide risk or harm to others. And this is kind of, can I take care of my basic needs? Is my patient able to meet their basic needs? So really basic. Are they eating, drinking, and protecting themselves from the weather are the main three things that we're thinking about when we're talking about, can a person meet their own basic needs? And if they're not, we're going back again to is this because of a mental illness? For instance, are they not eating and drinking because they think everything's poison? Are they not going out in the weather because they had, you know, a vision from God that they're not supposed to wear clothes? So these would be things that are more related to a mental illness, as opposed to somebody who is unable to do this because of their socioeconomic situation, perhaps. So they're not eating and drinking enough because they don't have enough money to get their food. And then we fall into are we going to report this? So this will tie in again to our mandated reporting for vulnerable adults. If they're not meeting their basic needs because of a mental illness, that's something you're going to consider for involuntary hospitalizations or it could be voluntary, depending on, I keep hitting the microphone, they must hate that.
We don't mind it, but maybe the
Right?
people.
So again, thinking about basic needs. All right, so since we're not really going to do a poll everywhere, who has either petitioned or certed a patient? Yeah, almost all of us. Okay. Did you get any answers in the text box from Blue Jeans?
No,
Okay.
I didn't ask for any.
That's okay. Well, I thought if they heard me, maybe they'd answer. But it's fine. So a lot of us have either done a petition or cert, depending on what our discipline is.
Okay. So, who, actually, why am I looking up here? I can look right here. Okay. So, patients whose psychiatric condition puts them at risk to self or others could require involuntary hospitalization. And in the state of Michigan, this requires 3 steps. There's a petition step, and any adult who has direct observation or knowledge of patient statements or behavior can complete a petition. So that might be the social worker at one of our clinics or a physician at one of our clinics. The next step is what we call a first certificate, and that can be completed by any physician who's examined the patient and agrees that criteria for involuntary hospitalization for danger to self, danger to others, or inability to care for self are met. And the petition and a first certificate are the steps that are needed to have a patient placed in a psychiatric hospital involuntarily. Okay? There's a second certificate that, again, we're not going to be worried about in our outpatient settings, but just so you understand the process, the second certificate has to be completed by the treating psychiatrist, and that starts a court process for involuntary hospitalization. And it has to be done within 24 hours of the first certificate. Okay? Patient remains in the hospital pending the court hearing. And while the patient's in the hospital, they can become a voluntary patient as this process is going on by signing in at the psychiatric facility. And once they're a voluntary patient, either the papers cannot be, it depends a little bit on timing, but no papers are filed, or if papers have already been filed, the patient has done something that they call defer the hearing, so that they don't have to go to court. They've agreed to get treatment. And a voluntary patient who then decides they want to leave, I don't know if any of you've looked at the voluntary form, and we didn't give that out today, but the voluntary form, actually what that says, when the paper they sign says, I understand that if the doctors think that I'm a danger to myself or others and not able to take care of myself, they can still hold me and make me involuntary again, or make me involuntary. So the doctors or the treating facility always has that option, even if somebody has become voluntary. Okay.
I think that this is sometimes where the idea of you've heard of the 72-hour hold, which isn't quite accurate, but people have this idea that there's a 72-hour hold, and that comes from, at least in Michigan, that the hospital has 72 hours to file with the court from when the patient wants to leave, and they have to stay in the hospital pending that hearing. It excludes Sundays and holidays, and it doesn't mean the hearing's going to be in 72 hours. That's how long they get to file with the court.
Can I ask a question I hear commonly about petition and first certs? Who would get called to court for this patient?
We're gonna get to that when we talk about the petition.
Primary care and the police officers get really worried about this, and the doctors.
So the easy answer is that the petitioner, the person who fills out that first piece of paper, which might be those of us in the room, is vulnerable to be called to court. Most jurisdictions don't bring the petitioner into court. They just take their statement on the paper, but not every jurisdiction. There are jurisdictions, particularly ones that are not conveniently located to where we are, that like to call in people, and that can be an issue. Okay, so in general, the people who go to court with the patient, in general, it is the person, it's the person who does the second certificate, the person who's actually treating the patient or part of that team. Yeah.
I noticed you wrote
Yes. Yeah. A petition could be done by somebody who sees, you know, a person behaving oddly on the street.
It could be the front desk staff even. So if they walk in the front desk and say, I'm going to kill myself, that front desk staff now has enough information to write a petition if that's what's required for this patient.
Although in general, what will really happen is one of the clinical staff will say, this patient walked in and said to our front staff, I'm going to come out. I mean, usually we're not asking the front desk staff to do that, but anyone can. And a family member can. So it just has to be an adult. So if a 17-year-old child is concerned about their parents' behavior, they cannot do a petition, but an 18-year-old child could.
And we'll talk some more about petitions and
Yeah, I
like
think
how that
that's the
actually gets
next
done.
slide. Okay.
Yeah.
So, petitions are typically completed, like we said, family, caregivers, social workers, police, nurses, although any adult can complete one. It's good for 10 days, and why they're good for 10 days is sometimes you can't find the person right away. So it gives time for police or others to try to find the person to get them to an ER. So the petition is good for a little bit of time. You can find them online. And I believe Kristyn passed some out to everybody too.
Everybody got a sample one that's filled out kind of in the areas where like, please fill this part out, and we'll go over it too together. And then there's a stack of extras of the samples if you feel like you need sample petitions. But you can find it online. You can also just search Michigan mental health forms.
Yeah, and it comes up. It's actually quite easy to find. So if you're advising someone to fill one out, or you're filling one out yourself, you want to try to provide as complete information as you can, but you can leave blank questions you can't answer. Of course, you do have to at least give them the patient name, because it's really not any good if there's no patient name. You also have to, in the first sections, which are basically danger to self, danger to others, inability to care for self, you have to check at least one of those boxes, and you can check more than one. You'll likely, in section 3, whoops, I'm talking about the wrong section, but in section 3, which is the danger to self, danger to others and stuff, you're going to usually check A, B, or C. D, I think we will rarely be using in our setting. D is actually a new option. The Michigan Mental Health Code was recently changed, and the new option is essentially allowing an option for hospitalization for someone who is seriously mentally ill in the community, having a lot of recidivism, not following through with treatment plans, and that's another way for the community mental health or police agencies or others to get them into a hospital. Usually checking only C is not enough. So that's basically the front page of the document. And on the back page, or page 2, you want to be as detailed as you can in sections 4 and 5. And then you want to check section 9 and complete all the information except the signature of an attorney. You want to use black ink, because some counties will throw it out if you've done it in blue ink, and the patient, no matter how sick they are, gets discharged from the hospital. If you make a mistake, you want to start over, sort of like if you write a check and you want to do it right. And the other thing is that you may be called to court, as Steve was asking about. Now, don't put your home phone number or address on this form. The patients do get copies of these in court. So unless you want to share that information widely with the court staff and with the patient, do not do that. Put your office information.
They'll even go so far as to throw out petitions that have holes punched in them or staples. So don't molest the form in any way.
Yeah.
They get really picky. most current.
The whole thing got thrown out.
So Elisa's point for people who didn't hear is that you want to make sure you're using the most current version of the petition. There's been times when the courts threw the case out because it was on an old form, despite the fact that you still had the evidence that the patient needed to be hospitalized. They said that that was an invalid petition. So I've been subpoenaed to Jackson County before, and they have specifically stated that I had to show up in person, that they would not take phone testimony. Any other place that has requested me to show up as a petitioner allowed me to do it by phone. But what percentage would you say of patients that get to a psychiatric unit involuntarily end up in a court hearing?
It's not very
It's not very
large.
many.
It's not very many. But it's always that, you can almost predict which patients it's going to be. I mean, people who have no
Delusional.
insight and are very delusional, they're usually very sick.
Certainly the majority will
But
either
most
defer their
defer
or
or
sign
sign in. Yeah. Now, sometimes, and I don't know if I say this on the next slide. Oh, here's the petition. So again, you want to fill out 1 and 2 because you have to say who the patient is. And then 3, you're usually checking A, B, or C, and it's better if you can get A or B and C rather than C alone, although I have seen petitions go through with C alone. And then more information on the back. There's questions here about things like, where was it? It was something, you want to check that they want to be hospitalized, but there was something that you were asking me about, do we have to fill this part out, that had to do with the court? It's the attached is section, that's section 7, is really for the court clerk to know what forms are coming with the petition.
So how, I'm thinking about the psychiatrist in the room who do telepsych, how does it work if you are meeting with a patient via telepsych? Are you the one to fill out the petition, or do you rope in somebody that's in the clinic?
I do not know that the Michigan law has commented yet on telepsych. I think you'd probably need to get somebody to see the patient in person.
I
But-
would probably not fill out a petition because I don't want to get called to court.
That's what I was thinking. in the
Yeah,
RFP.
yeah. Well, and I think probably that you would, if you thought if somebody needed to be petitioned, you'd be talking to your partners, so partners on that side, to do a petition and take the person to a hospital where somebody else would do certain
I
stuff.
think it's trickier, if we ever, we don't do this right now, but some places do home televideo visits, right? And if they're at home, that's the.
Well, I think what you'd do if they were at home and you were really worried, you'd call the police and you'd get the police involved,
Yeah,
yeah.
so you're not, and I don't think you're going to do a petition if it's a distance consult anyway, because it has to be the original. You can't even send a copy
Yeah.
in. It has to be
You
the original.
can't fax it, you can't, so somebody would have
you
to
wouldn't.
drive the petition if you did one up to
Yes.
the Upper Peninsula. And there have been times where a petition has like been left in the ER and we've sent a car service with it or a cab because it's the only thing, they need the original.
I will, one thing about police, I got burned a couple of times, especially like when I was in Detroit, it was a very busy police service, that we wanted to bring them there, and they would not write the petition. Yeah, so with police, if you're in an area. It's on. If you're in an area, depending on your police, you kind of have to know your police sometimes. But if the police do not observe the behavior, they will not write the petition, right? So if the person's like violent and going off the chains, then yes, they're observing. But if the patient says they're suicidal to you and they won't go on the ER, and ambulances often won't take people if they don't want to go, right? So the police will not be the ones who write that they're suicidal. If they ask the patient, I'm not suicidal. So you just want to be prepared for that, because depending on where you are, some police, like in the Thumb, I have some where the police are very nice with this clinic and do everything, in other places where they're not going to write the petition. You better have it with you or else they're going to leave.
Yeah.
So I don't know if anybody else has run into that, but I've been burned a couple times
And
with
there
that.
have been issues here on campus with there have been issues on camp with public safety and Ann Arbor Police. So sometimes all you can do is say to the police, we're really worried about this patient, can you do a wellness check? But if the patient doesn't say to the police, I'm suicidal, they may not bring them in. And I think what you're doing in those cases is you're documenting what you did. There's only so much you can do. We should keep going.
Yeah, let's move along.
Let's see. So most of the time what you're going to be doing is arranging for a patient to be taken to an emergency department. In general, it's best if you can do that in their county of residence, especially if they live in Oakland and Wayne County, because Oakland and Wayne County do not have reciprocity with other counties in the state. And that means that if a patient is in our ER here at, let's say it's a patient who's coming from the Northville or the Canton Clinic, and they get sent to U of M's ER because it's a U of M clinic, we then really, we're not going to be able to admit that patient to U of M if it's an involuntary admission. We're going to have to then turn around and work with Oakland and Wayne County. And part of it is our trying to avoid unnecessary work, but a lot of it is that it's really miserable for the patient, because what happens if you land in another county's ER and you're from Oakland or Wayne County, Oakland and Wayne County will literally let you sit in that ER for days. And there's not much you can do to move the process along to get the patient hospitalized. So it's something to think about depending on where you are clinically.
It's especially true for the Medicaid population because they need their county residents, CMH, to authorize it. So those are the ones that are really going to get stuck. St. Joe's is admitting involuntary Wayne County patients to the Ann Arbor psych unit. So
they are, okay.
And that's been new in the last couple of years.
Yeah, so U of M
But they'll
does
get
not.
stuck.
U of M does not do that. So, again, it's a county of reciprocity issue that they, Wayne and Oakland require us to take the patient to a Wayne or Oakland County court, which requires, if it's really an involuntary, very ill patient, just requires nursing and security and secure vehicles, and it becomes quite a hassle. So if it's any other county in the state, we do it by tele-court. So if you're petitioning, you're probably going to have a patient brought by ambulance. Now, if you think that the patient's at risk, let's say it's somebody who really is suicidal, you're really worried about them, but they want to go to the ER, or they're willing to go to the ER, and a family member is willing to take them, and you feel comfortable with that family member taking them, you can let them do that. I mean, you don't absolutely have to send them on a petition, but it's really, again, a clinical judgment of whether you're comfortable doing that. If you want to make sure they get safely to an ER, it's probably better to do the petition and send them by ambulance.
Teague.
One of the clinics that we're going
Plan on going to.
See, so the question is, what if a patient who's voluntary, says they have a plan, wants help, wants to go to the ER, and the clinic sends them by Uber, taxi, Lyft by themselves? Again, I think that's a clinical decision that the person making that decision has to make. I mean, if they called us in the psych ER and said, we have this patient here who says she's suicidal and we're going to send her by Lyft, we would say, really? Are you sure you don't want to put her in an ambulance and petition? But I think it has to be sort of your decision. I mean, I will send people as voluntary patients to Chelsea Hospital. I personally will send them from the psych ER as a voluntary patient to Chelsea Hospital with family, without a petition, without an ambulance. But I do that with select patients.
Right, and with a person.
And it is with family usually, yeah.
Yeah.
If you get a call to the ER and someone at home saying,
We usually would talk to them about how will you get here?
okay,
And how will you be safe getting here? But we may recommend that they come on in rather than calling an ambulance. It really, again, it really is, I think we have to, I mean, I guess the way I think about this is we waste a lot of money in our system transporting people by ambulance who probably don't need it. So I think we do have to make a judgment call, but in general, if it's an unknown patient and we're not sure they can get there safely, we would probably send an ambulance. But if it's somebody you can say, are you there alone? And they say, no, my boyfriend's here. Can I talk to your boyfriend? And you can actually talk to the boyfriend on the phone and say, can you bring her right here? I might do that. But, I think it's hard. Because I really, when we're on the other end of it, waiting 10 hours to get an ambulance to transport somebody to Chelsea because all the ambulances are busy. And, you realize that maybe there's somebody whose family member could have driven them, so I don't know. I don't know what the right answer is.
And Teague, for your question about, what about an office that wants to send their patient in a Lyft or an Uber, I would say I don't expect any of the people on our team to override what the practice manager says is their process. So if that's what their process is, that's what their process is. It's not our job to enforce any kind of policy on that practice manager, if that makes sense. I might advise them like, oh, are you sure that's safe? But I'd absolutely let them do what they think is the process for their office. Yeah. Right. True, and if we filled out a petition,
if
our
we filled out
policy
a
is pretty clear
petition-
that they go in an ambulance when you read the suicidal ideation policy for IHA. So you could remind someone like, oh, I think the policy says this. But if it's somebody who's going voluntarily, they're going to, there's wiggle room.
Wendy, were you going to ask something? Sometimes they want a cert. It's not that straightforward. And, okay, the question was that a patient can go by ambulance with a petition, but some ambulance companies in some jurisdictions will want a cert.
Wow.
So, I mean, this gets really complicated. And these are the kinds of calls we're fielding in the Psych-ER from other clinics and places. But usually a petition is enough to get them to a hospital for an assessment. Okay, so once a patient, let me go through this really quickly because we're running low on time. So once a patient is in the ER, what do we do? Well, we're going to evaluate them, and depending on what ER facility they go to, psychiatrist, social worker, or only medical staff may evaluate them. The patients can be discharged with safety plans. They can be admitted as voluntary patients because they agree to stay and everyone thinks that's reasonable. They could be admitted as an involuntary patient. And again, a lot of patients, like Kristyn said a few minutes ago, a lot of patients who are admitted as involuntary end up signing in. The ones that we usually will not let sign in are those who we think need an alternative treatment order or outpatient order, a court order for outpatient treatment. Or if we're worried that they have guns, because the only way to get on that database to not own guns is if your case is actually adjudicated in court. So you would, if there was somebody who you were really worried that they had guns out in the community, you might go through the process of an involuntary just to get that taken care of. And I think the patients have to know that they're going to be in the ER for a long time. I think 8 is probably, is that 8 what the St. Joe's average is now? Is that where you came up with that?
There's certainly patients that get to their disposition in 4 hours. I think that patients need to be ready that it's going to be 8 as a starting point.
And I think 8 is probably short. At least at U of M. I think that's a very optimistic estimate.
It's a long time. They're going to be in the emergency department a long time. And there are also patients who are going to be there for a couple of days, and we all hate that about the system.
Or a couple of weeks. Sorry.
And at the same, it happens.
It happens, yeah. So so it's not a great system. In fact, we will have people who are stuck in the ER who we begin treatment, and we end up basically doing their whole psychiatric hospitalization in the ER and discharge them. Because they're stuck in our ER for whatever reason, and there are a variety of reasons. But the other thing is to think about where they're going. I don't know, St. Joe's, I'm assuming they get assigned to a bay or a bed, and that's where they stay if they're in the ER? I don't know.
Yeah, they stay, wherever they got in, they stay there until a bed's found.
Okay, because at PES, I don't know if anyone's ever visited PES, but PES is essentially a clinic. So we have interview rooms and we have a lobby, and sometimes if you're stuck staying there, you're literally stuck sitting in a chair for days. So it's not the most pleasant place in the world. We're working on getting some holding beds and such, but right now we don't have them. And it's really awful for patients. Not to say that we don't do it if we think the patient's at risk. We have to do it, but something to think about. So. Okay, you take this.
Sure, and I know we are going to wrap up, so I'm going to fly through these. Children and adults can be at risk for abuse and neglect. So thinking using your clinical judgment if the patient is vulnerable because they're a child or they're elderly or they have a disability. And then once you've determined if they're vulnerable, are they at risk for abuse or neglect? So non-accidental physical or mental injury, the sexual abuse, sexual exploitation, inadequate food, clothing, shelter, medical care. So those are the basic definitions. And I'm saying this because I'm going to go back to being mandated reporters. I think that everybody who's a social worker certainly has had this drilled in. So we don't have to spend a lot of time on it. Physicians, social workers, nurses, almost everybody in healthcare, everybody in education, mandated reporters. So remember, you have to report suspected abuse, neglect. You need to do that immediately by phone when you have when you suspect the abuse, neglect. You don't have to decide if it's true or not. You just have to suspect it. You make a phone call. That's a central number for intake for the abuse, neglect. And then you have to follow that up within 72 hours with the 3200. So I gave everybody a sample of that. It's not filled out, so that's totally blank. You can take more if you really want them. They're also online. And there's directions for how to fax that in right on the 3200, and they'll tell you about that when you call in. So it's not too hard to make this, and you just tell as much information as you have. Children's Protective Services is investigating allegations of abuse and neglect from birth to 18. Not for unborn children and not for 18-year-olds. So just think about that for your parameters. And again, the alleged perpetrator, when you're talking about Children's Protective Services, needs to be somebody who's in charge of the child. It can't be like somebody at school beat them up. That's not Children's Protective Services. If it's somebody who's in charge of the child, that's the kind of thing that gets reported to CPS. So that was the anybody filed a 3200? Yeah. Right. Here's what it looks like. I gave everybody a copy. The back has some additional information that's filled out if there's a physical exam. Doesn't have to have a physical exam to make this report. And then again, instructions for filing it by fax. Thinking about vulnerable adults. So again, our profession mandated reporters for vulnerable adults. I just listed a definition for vulnerable to help us think about what do we mean. We're talking about somebody who can't protect him or herself because of a disability or advanced age. And then exploitation as well. This happens when somebody might be using this adult's money instead of caring for them to do their own kind of thing. So we want to think about exploitation of vulnerable adults as well. You report it to the same number. You don't have to file a 3200 for adults. Domestic violence. There's no mandated report for domestic violence. So there are some injuries that physicians have to report from violence, like gunshots, knife wounds, and the other things. When you read the law, it's social workers. We don't have to do that. We don't have to report domestic violence if there's a pregnant victim, unless this is because of other children that are in the environment. So this could be a CPS mandated report situation if you have kids or vulnerable adults in the home that are at risk of abuse and neglect because of the domestic violence in the home.